Once again, thank you everybody for attending. My name is Jason Higginbotham, here to talk about the Acuity PM1 handheld non-contact pachymeter. Pachymetry we'll talk about in a moment, but just moving on regarding the technology that Acuity produce. The PM1 is the first of several devices that are all handheld and portable. They use non-contact technology, and they don't require any consumables. They're much easier to use for both the clinician and the patient. So that really makes a difference to the end user and the overall experience that patients have. The devices have small footprints, they're rechargeable, they're easy to use, very portable. Because they're non-contact, they reduce any risk of cross-infection. And it also means that you don't need any anaesthetic as opposed to an ultrasound-based pachymeter, for example, and you don't need as much in the way of sterilisation post-measurement. And it's also quicker and easier to use than ultrasound pachymetry, for example. But that's the ethos of Acuity. It's more than just, in this case, the PM1. Other devices, such as the upcoming AX1, for example, are also handheld and portable. The PM1 is a great looking product. It was designed by a gentleman who was formerly a designer at Apple, and I think that is very clear and evident in the sleek lines that the product has. But it's also ergonomically designed, so it's very, very lightweight, easy to use, easy to hold. And its features and benefits compared to other devices, as I've mentioned, it's non-contact, so much, much easier for the patients to use. It's handheld, very lightweight. You don't need the desktop space that you would do with the larger desktop devices. And it is accurate, very repeatable and accurate, and reliable. So, of course, that's important in clinical settings. And moving on, other features and benefits. As I've mentioned, the reduced risk of cross-infection is very important. That was fairly recently very, very important, of course, with COVID, but there are still plenty of other situations where the lack of contact is very, very important. As I've mentioned, very, very easy to operate, but because it's faster, it's reduced chair time as well. Having worked in laser clinics myself, and I used to do ultrasound pachymetry early on in a consultation, we would measure tonometry using the Goldman, and we'd have to put anaesthesia in, and then maybe even repeat the anaesthesia in some cases to do an ultrasound pachymetry measurement. And of course, then you'd have to wipe down the probe, etc. And that took time, and it took minims, single-use drops and things like that. So more expensive in the long run using contact ultrasound devices, and just less convenient. So other benefits, as I've already mentioned, cost-effective and sustainable. There's wireless charging, so you don't have to replace batteries as you generally need to do on other pachymeters that are handheld. No consumables, as mentioned, you don't need anaesthetic drops and so on. And cost effective, not just because of the reduced need for anaesthesia, etc., but also because it's faster and easier and you don't need to replace batteries. So let's compare the PM1 to ultrasound handheld pachymeters. The technology is optical, and with that it's also therefore more reliable. Ultrasound pachymetry, you do indent the cornea ever so slightly when you connect or contact the cornea, so the measurements aren't quite as accurate. This is non-contact but has a central alignment system, which means you're measuring the same point on the cornea most of the time, whereas with ultrasound-based devices you could measure superior, inferior, for example, and not measure the same point every time. And there will be multiple points of contact, quite possibly. And the time it takes, therefore, having to instill drops, etc., means it takes longer with ultrasound-based devices. There is a risk of minor corneal abrasion, usually minor, and therefore also, because of the contact, a risk of cross-infection if you haven't properly sterilised the probe. And as mentioned, you don't need any drops at all. Anybody can use the PM1, whereas with an ultrasound contact-based pachymeter, usually it's somebody who's specially trained or even a clinician. The training as such is minimal, if at all, if any, for the PM1. It's a little bit more involved for ultrasound pachymetry. And there's a good touchscreen display on the PM1 with a nice camera to help align. There's just an LCD screen on a US Pachymeter. And you can use it anywhere because it's portable and chargeable. And really, it's not something you would use outside of the consulting room, the ultrasound pachymeter. So in terms of cost-benefit analysis, the direct cost savings, obviously no anaesthetic required, no sterilisation required. You don't require replacement pachymeter probes, as sometimes is necessary, or any sterilising wipes and so on. But because it's faster and easier and reduces the risk of injury and disease, and it's more sustainable, there are indirect cost savings. And if you look over, say, a 3-year period, at a fairly slow clinic, if you were using Pachymeter drops and sterilising wipes with an ultrasound pachymeter, that will add up to a fair amount of money, probably about £1,200 over 3 years, which if you add that to the cost of an ultrasound pachymeter, makes it actually ultimately a little bit more expensive than the PM1. So why use pachymetry? And that may sound like a silly question, but a lot of people think it's only used for glaucoma refinement of intraocular pressure, but certainly not. It is used in many other circumstances. Glaucoma obviously is one area where pachymetry is very important. We know that tonometers assume a certain corneal central thickness for maximum accuracy, which we'll get to in a moment. But also it's important to know that if people have a thin cornea, they're at a higher risk of glaucoma. Corneal clinics, again, rapid screening for the presence or otherwise of particular conditions. So even central corneal thickness will be reduced in keratoconus, although the thinnest point is usually more inferior on the cornea, as in pellucid marginal degeneration as well. But still, if central corneal thickness is reduced significantly, then that's a rapid indicator that there is something that requires further investigation. Whereas if central corneal thickness is perfectly normal, that's a good sign for a great deal of patients in corneal clinics. As I've mentioned before, I used to work in refractive surgery myself, and rapid understanding of the central corneal thickness helps you to tailor the consultation that you provide. So for example, if there's a patient who's, say, -4 with a moderate sized pupil, you need to ablate a fairly substantial amount of central cornea. But if they've only got, say, a 500 micron cornea, you're unlikely to use LASIK, where a flap is produced. You may instead use LASEK, where the epithelium is moved to the side, allowing a little bit more residual corneal stroma, for example. And that just means that you tailor your consultation then to that patient's requirements. It may be alternatively in refractive clinics that you realise that due to their level of refractive error, they're not suitable for laser, but may be suitable for refractive lens exchange. And again, rapid pachymetry will help you understand that. Cataract clinics, it's very, very important to understand the risk of endothelial damage and decompensation of the cornea post-surgically, which can happen because the ultrasonic probe does kill endothelial cells, the back surface of the cornea. And so if a patient has a risk of or early signs of Fuchs endothelial dystrophy, you will change the method of cataract surgery or reduce the energy used in the ultrasonic probe, for example. And again, if somebody has a very thick cornea prior to any further consultation, so say 600 microns or above, you're likely then to put them through specular microscopy to actually do a cell count, etc. So again, very useful for rapid screening. Or if a patient has a very dense cataract and an ultrasound A scan is required, they'll also need pachymetry for some of the IOL calculator calculations or formulae. So again, very useful in cataract clinics. But also there will be, and there are, a great many academic studies out there and research studies on a whole range of conditions, not just corneal, but often corneal. And again, this device being fast, easy to use and reliable is ideal for those kinds of studies and used in many universities and teaching hospitals and so on. But also in myopia management, there's growing evidence that understanding the pachymetry will give you some understanding of the risk of myopia progression, but also if you're conducting myopia management with contact lenses, whether they're soft or hard orthokeratology, then it's a good idea again to understand the cornea very briefly as a screening tool with pachymetry. Then of course you can look more closely at other issues if it's very clear that there are some, for example. So just moving on to glaucoma and tonometry and pachymetry. So just a very, very quick little history of glaucoma. So it was first considered a condition way back in the 10th century by the Islamic scholar Al-Tabari, who understood that there were patients with marble-like or hard eyes who lost their vision, and that's the first time that it was evident that some form of build-up of pressure in the eye was the cause of visual loss. And an English physician in the 17th century suggested using his fingers, known as digital palpation, to actually build up a technique for measuring the pressure in the eye. And up until the late 19th century, early 20th century, it was still considered a valid technique. Not anymore, I might add. Then Ernst Pfluger theorized the link between the pressure in the eye and glaucoma in the 1930s, and glaucoma-associated changes of the optic disc. Since then, probably the most famous clinician in ophthalmology of all, Professor Goldman, came up with the applanation tonometer, the Goldman applanation tonometer, in the 1950s, using what's known as the Imbert-Fick law. Now, the Imbert-Fick law is a theoretical law designed to measure the pressure within a sphere which is surrounded by an infinitely thin membrane, which doesn't exist in reality, apart from now in space. If you had a ball of water in zero gravity, you could applanate or flatten a small area of that ball of water to work out the pressure within. And so, of course, corneas aren't infinitely thin, they have a thickness, and that's why you have to utilize or understand the corneal thickness to be able to manage what the real intraocular pressure is. But Ehlers and some other physicians found out that if the corneal thickness was 520 microns, then you didn't need to make any change to the intraocular pressure as measured with the Goldman. So in other words, it's calibrated for a 520 micron cornea. Latterly, devices such as non-contact tonometers generally show the same effect, but for thick corneas, roughly 545 to 554 microns, depending on the device. And so again, if you know that the patient's corneal thickness, you can calibrate or recalculate the intraocular pressure depending on both the corneal thickness and the tonometer used. So again, the Imbert-Fick law states that the force required to flatten the spherical surface correlates with the internal pressure. And as I've already mentioned, the main assumption is that the cornea, obviously, it does not have is not infinitely thin, and therefore we have to measure that central corneal thickness. So in terms of the current trends, latterly, people have not moved away from pachymetry, certainly not, but they've possibly moved away from correcting the intraocular pressure as accurately as they used to, though some do feel it's essential. Others feel it's just as viable to say that the patient has a thin or a thick or a normal corneal thickness, and that will help the ophthalmologist or surgeon understand if their risk of glaucoma is increased or reduced. But other clinicians still prefer to use the formulae, especially where LASIK and LASEK have occurred, because that affects the corneal hysteresis as well. And as I've mentioned, Ehlers found that the Goldman applanation tonometer is most accurate in the 520 to 560 micron range, but is only completely accurate at 520 microns. Most people assume the average corneal thickness is 550 microns. I hear that every time I do a talk. But if you look at most meta-analyses, Cochrane reviews, and other systematic reviews of average corneal thickness, it varies dramatically with age, gender and ethnicity. And in some countries, continental India, for example, I think the average is less than 520 microns. And in other areas, it's higher, maybe 540 microns, but I've never seen an average corneal thickness of 550 in any population study. People have mistaken the fact that non-contact tonometers will often use 550 microns as their 0 point. They don't actually use that. It was just found that when the cornea was 550 microns thick, there was no need to correct the intraocular pressure measured by that non-contact tonometer. And as I've already mentioned, corneal elasticity and hysteresis are still important and need to be measured really to truly understand the effect of all of those different features of the cornea on intraocular pressure. Out of interest, the effect of a thicker or a thinner cornea also increases with age because the cornea stiffens. And so if you need to adjust a intraocular pressure by, say, 1 or 2 millimeters mercury in a 25-year-old, it may be as high as 8 millimeters mercury in a 65-year-old. So that's something that's often misunderstood as well, but useful to know. So at that stage, I think it's important that now you've got a rough understanding of pachymetry and the uses of pachymetry, etc., that we actually do a little demonstration of using the device. So we're going to get our friendly model along in just a moment. You can visit the Acuity YouTube channel to see a user video as well, which is quite important, I think, so you're aware of that. And if we haven't already, we can send you a link to that too. Very, very quick, informative video. It's the first time that day, it will ask you to calibrate on the charging base, which has a little tool here to calibrate that it's working effectively. So if you look into the corner, please. Now, you'll see a little blurred red light in a moment. If you can look towards that. There we go. I'm just going to bring this into position. There we go. So that's the first measurement. It's come up in yellow, which suggests I was probably moving a little bit, shaking. But let's try that again. And it's not nerves. Let's keep looking straight here. Incidentally, sorry, I put my fingers on your forehead, but that's a good idea for clinicians to do, is to rest 1 or 2 fingers on the patient's forehead, because it's just easier to remain stable as possible in my case. So once again, if you look roughly at the blurred red light for me, please. That's great. So it's hard to see on here, but if you look at the video that we've got online, there's a little horseshoe symbol or target. And I'm trying to line that up. Not doing it very well at the moment. There we go. There we are. Much better. So we have a green result now. There we go. Which is the measurement with a level of confidence next to it. Can you all see that? Yep. I'd love to keep my audience riveted and just look straight over into that corner again. Much easier. You can see after just a few seconds, I haven't used it for some weeks, but right back into it. And there's the average reading. So very repeatable, very accurate. 520 microns bang on in this case. We didn't know that. So if we used a Goldman tonometer to measure the pressure with this patient, there would be no difference with the intraocular pressure measured from the Goldman compared to using the corneal center thickness to calibrate it. Whereas if we'd used a non-contact tonometer, which would assume, say, 550 microns, then that's a 30 micron difference, and we would actually have to alter the intraocular pressure fairly substantially, because it would underestimate the IOP in this particular case.
So it's my advice in this situation where there are 2 amber results, delete those ones out, because of course it doesn't cost anything or take much time to get a more accurate reading.
True. Looking at here, 518, 524, 519, They're all very, very close together still. They're very bunched up, which is a good sign of repeatability. But it's a fair point. If you wanted all three to be green, you could repeat the measurements, certainly. And usually they're all green. It's probably just the fact that it's a Monday morning, or well, almost Monday morning. There we go. So let's do one more measurement. Can you all still see me over here? There we go. If you just look once again into that corner, thank you. So once I line up centrally, it automatically starts to measure. And there we have a green measurement once again. And I'll do another one. We normally do 3, of course. Good, and I'll do one more. Perfect. So there we have all 3 green and a good result, and 531 microns, which is not a lot different from the other eye, as we would expect. And again, if that was on a Goldman tonometer, it would underestimate the intraocular pressure by about 1 millimeter mercury, and that's how it would be used. So,
can I ask you something?
You can indeed.
It's Marianne here. You ask her to look at a point.
Yes.
Before you start to measure, but shouldn't the patient look into the device?
As I mentioned to the patient, it's just to help line the eyes in a direction. And once I introduce the device, as I mentioned to the patient, they see a very slightly blurred red light, which they just need to look at. And then it will help you to align. But I like to, as an optometrist myself, prefer to get them looking in one direction, so it's easier for me to actually line up the device with their cornea.
Okay, and it doesn't matter how you put the device against the cornea?
Well, you're not touching the cornea, but if you come in too steep, it won't really line up for you, but you very quickly learn, especially with putting 1 or 2 fingers on the forehead, to come in essentially perpendicular to the corneal surface, and it's very, very easy to do. As soon as you get in roughly the right plane or angle, it starts to automatically measure, and then you're aligning a little horseshoe symbol, which, as I say, you'll be able to see on the YouTube video that we have. You can actually see it. It's a little kind of almost complete circle, but not quite, and you align that with the reflection of the circle on the patient's cornea, and then you know you're in the right place all the time.
But sometimes I think it's the white horseshoe.
Yes.
That change size. You have one size and suddenly it's much smaller.
Yeah, it does. Yeah, I mean that is the alignment mechanism. So it does, tell you how far you are away from the eye and how close you are to it, and that will change. I've experienced, using the device a lot now, and I've seen other people use it as well. And it is very much as Jason said, no training is required. You can pick it up, and as long as you've got building blocks, the general knowledge of how it works, then it's a case of using it. And the more you use it, the better you get. And those icons become more intuitive. You just get a feel for where it's at.
Very much so.
But when it gets so small, is you too close, or are you too far from that?
If it actually gets small, it's better to move in further, because you're looking at the coloured horseshoe as well, which is on the LCD screen, and obviously the other horseshoe is actually a reflection on the cornea. And so you find as you move in that it gets bigger and your coloured ones get smaller, if you see what I mean. You're trying to match the size of them and obviously align them. And you very quickly work out, it's very intuitive. As you move in and out, you can see the size of both of them changing. And as long as you align them closely or fairly closely, it automatically measures, and it takes seconds and probably 2 or 3 attempts to use it. It just becomes more and more intuitive and easier to use.